drug will be also approved in Europe by the European Medicine Agency, we will need to face these side effect of the monoclonal antibody therapy against Alzheimer's disease, and these side effects are called ARIA. And here are my my disclosure. So what are the ARIA? ARIA is the acronym for amyloid-related imaging abnormalities, which are represented by imaging abnormalities on magnetic resonance imaging, MRI imaging. And so with this talk, I would like to gain an understanding of the ARIA, and in particular the two types of ARIA that can manifest in patients exposed to these drugs, which are called ARIA-E and ARIA-H, and also to gain an awareness on the relevance of ARIA in clinical trial, not only in clinical trial design and drug design, but also in the interpretation of the current outcome that lead to this approval. And also to gain an awareness of the relevance of the identification and, most importantly, in the management of these events, the side effects during exposure to the drug. And we will also discuss on the theoretical but also very practical implication and the challenges that we will need to face if this drug will be available to the broad audience of Alzheimer's disease patients now that is supposed to be on the market, at least in the US. And in the end, we will talk about the ARIA paradox, etiopathogenic model of these ARIAs, and the importance to understand the mechanisms that lead to these side effects, because only understanding these effects, we will also improve the drugs and reduce the incidence of these effects, side effects. So coming back to ARIA, what are they? ARIA are MRI abnormalities that was first reported in 2009 after the trialists, they observed an increased incidence of these imaging abnormalities after treatment with bapineuzumab, which was the first monoclonal antibody used in clinical trial for Alzheimer's disease. ARIA was represented by white matter hyperintensities that are signal change suggestive of vasogenic edema, so likely related to inflammatory reaction in the brain after the exposure to this drug. And also some imaging abnormalities representing hemosiderin deposits, so to cerebral microhemorrhagic, so brain bleeding related to the exposure to the drug. So since there was this very high incidence of this event in treated patients, the FDA and the Alzheimer's Association, they thought to represent that this was a side effect closely related to this anti-beta monoclonal antibody treatment. And they established a working group and a roundtable in 2011, where they coined the two acronyms, ARIA-E. As I said, they represent vasogenic edema, so inflammation, and in the parenchymal brain of this patient, and sulcal effusion, so the release of proteinaceous fluid, the effusion of fluid, again, related likely to inflammation on specific MRI sequence, which are called flare sequences. While ARIA-H represent the hemosiderin deposition to the surface of the brain, and these are due to brain bleeding events and are recognized as cerebral microbleeds, cortical superficial siderosis, or large microhemorrhages, so intracerebral hemorrhage. And again, to visualize and to recognize these two events, you need to perform specific MRI sequences that are called grade 2 star, or the more recent SVI sequences. So more specifically, the ARIA-E are visualized, as I said, on flare, and as you can see in these images. In these images, they could be they can reflect parenchymal hyperintensities, as you can see here, when we compare the baseline MRI scan of a patient before starting treatment and after treatment, during treatment. Or they can be represented by sulcal hyperintensities, as you can see here. So the hyperintensities on the MRI in the sulcal space. Or again, gyra swelling, so these small and more difficult to recognize image abnormalities after treatment with the drug. So also this complex interpretation of the results immediately recall also the importance to education and to have very skilled neurologists to read the images. And in fact, as we will see during the presentation, by a retrospective analysis of all the MRIs collected in all the clinical trial performed till now, they found that there was more than 80% of these abnormalities that they were originally missed in the first analysis. The nature of ARIA-E at presentation, so during the acute presentation, is related to inflammatory event, so edema and effusion or exudate. But at follow-up, we also know that they typically resolve at 3-6 months of a follow-up when the patient particularly stop to receive the drug. But now with the new titration plan, we will also see that these events are being slightly reduced in the incidence. And if you reduce the dose at the same time, you can also have a resolution of the disease after 3-6 months. The location is parenchymal or into the leptomeninges, so is more, at the cortical level and not in the deep white matter. And the presentation, so the clinical presentation of symptoms is very variable. At the beginning, with the first clinical trial, was more aggressive and more severe. But today, we learn more how to try to manage and to reduce the symptoms of this drug, such as the titration plan and stopping of the administration of the drug when you recognize the incipient occurrence of this event. I would say that the symptomatology is reduced to about 20%, while most of them are asymptomatic. Even if we will see that up to 55% of patients, they develop these adverse events during the treatment with monoclonal antibodies against beta amyloid. So in the past, they also develop an MRI rating scale to try to rate the severity of these
can you hear me?
events, while the significance of these events, as we will see in a few minutes, is still large unknown, or I would say there is a lot of work to do to understand the meanings of these events. ARIA-H, the specific sequence are GRIT to star or SY, and they represent the imaging abnormalities related to blood degradation products that can deposit on the brain after bleeding events. And as you can see here, are represented by these small black dots, so previous or previous microhemorrhages events after treatment, or cortical superficial siderosis that are represented by this hyperintensity signal, again representing the deposition of hemosiderin, so ions, after bleeding event, in particular after the deposition of this iron after bleeding events. So the symptomatology is again very variable and is represented by the typical symptoms that can manifest in cerebrovascular diseases. There are no specific rating scales to rate the severity and the magnitude of these events specifically related to immunotherapy. But I would say that we can easily apply the rating scales applied for cerebral amyloid angiopathy, because all of these markers are the same marker that we currently use in clinical practice to diagnose cerebral amyloid angiopathy, So the only one difference is that we can talk about ARIA-H only if these events, they occur after treatment, while in a patient not exposed to any drug, we will simply call that marker of CAA disease. So the ARIA-E and ARIA-H have been subsequently found in almost all therapy trials with monoclonal antibody, not only bapineuzumab. And so they are really related to the clearance effect of anti-beta monoclonal antibody. So the drug effect in the removing of beta amyloid. Concerning the risk factor for the incidence of ARIA, these are the most accredited risk factor, and in particular is the dose of the drug administered, the ApoE epsilon low allele, because most of these patients, they are ApoE epsilon 4 carriers, the time of exposure, and the type of drug administered. So concerning the drug dose and ApoE epsilon 4, as you can see here, again, in the retrospective analysis of bapineuzumab, we see that there is a very clear dose-related effect in the incidence of these serious adverse events, and also an ApoE epsilon 4 association, because most of the patients, they were ApoE epsilon 4 homozygous. Concerning the underlying CAA pathology present at baseline of these patients, even if it has not been very carefully evaluated and I would say reported in all the patients, the author, they also found an association between the occurrence of these events and the CAA severity by means of increased number of cerebral microglia, so the black spots that I show you that represent the main markers of CAA. The occurrence of ARIA-E also has been demonstrated to occur mainly between the first and the third infusion in first clinical trial, even if today with the titration plan, so with the administration of increasing dose of the drug on the clinical trial to try to reduce these adverse events, today the incidence has been shifted in time. And in fact, if you try to see the technical annex of the FDA approval for ADUCANUMAB, they recommend to perform an MRI scan before the 7th and the 12th infusion. While in a clinical trial up to date, an MRI was mandatory before each infusion of the drug, monthly infusion of the drug, in order to timely recognize the incipient occurrence of ARIA. While the incidence of ARIA decrease as the duration of the exposure increase. So this means that the incidence of ARIA is reduced at very late stages of treatment. And the similar trends have been also observed with the incidence of ARIA-H side. And so coming back to this paper that was published a few years ago on ADUCANUMAB, where they, for the first time, they show that there was a very clear removal of beta amyloid from the brain of these patients, Alzheimer's disease patients, and that the removal was markedly associated to the dose of the drug. So when patient treated with 10 milligram per kilo, there was quite an almost total removal of beta amyloid compared to the baseline scan with an amyloid tracer on PET. But what that was less reported was this table that was reported in the supplementary material, where I was immediately surprised by the high incidence of ARIA-E that reached 55% of ARIA-E in patients that were ApoE4 carrier. And another important finding is that 35% of the patients that they develop an ARIA events, they also drop out the trial. So meaning that this is also an important consideration to take in account if the drug will be used in the everyday clinical practice. And another important findings that has been reported is that the ARIA may be related to the clearance effect of this drug. As you can see here on the left, this is again an amyloid PET image with a trace specific beta amyloid, and in the same brain area where an ARIA event has occurred, there was a greater reduction of amyloid on amyloid PET after 19 weeks of treatment with the bapineuzumab antibody. And the same was also reported with gantenerumab, which is another antibody by Roche, where in the same brain area, again, you have the measured removal of beta amyloid after treatment. And so these findings suggest that there is a closer relationship between the amount of the clearance of amyloid exerted by this antibody and the potential occurrence of ARIA events. And so ARIA-E may not only reflect, may not only represent an adverse side effect of the treatment, but also the proof of the drug engagement and the effectiveness of this drug. In particular, an exacerbated removal of brain amyloid deposited in the brain that is dissolved, disaggregated, and removed by these drugs. Concerning the impact of this side effect on on cognition or function, the data are very, very scanty. There is only this report, again, on a retrospective analysis in bapineuzumab, and it seems that there are no clear differences between the patient that they develop an ARIA-E events compared to patients that they did not. However, we have to take in account that the same retrospective analysis showed that more than 80% of the patients, they were not ApoE4 they were not amyloid positive on amyloid PET at the baseline, meaning that there was some recruitment concerns in these initial trials. And so even if, and also we have to consider that if ARIA is strongly related to the ApoE4, which is the main risk factor for Alzheimer's disease and the severity of the disease, we should expect that these ARIA-E patients, they have a more rapid progression in terms of cognitive decline, which is not. So it means that maybe these events are only, I will not say helpful, but they reflect also the measured removal of beta amyloid, but data are not clear, and so we have to investigate better in other cohorts. And concerning the association between ARIA-E and ARIA-H, to see if there is a close relationship between the bleeding and the vasogenic events, inflammatory events related to the therapy, again, the data are not very, very clear, and about 50% of the participants, they develop both the two types of ARIA, and 25% have ARIA-H first and 25% after after they develop ARIA-E. So data on region, location, the size, and the severity of occurrence are very limited, and so we need to better investigate also these very important aspects. And again, we also have to be careful in evaluating this previous report because of the bias and the issues that I told you. And in particular also because the FDA recommended to do not include any patient in clinical trial with more than 5 cerebral microglia at the baseline, in particular because the recognition that this drug can lead to bleeding events. And also, we have to consider that in previous trial, in current trial, usually patients that they develop an ARIA-H, so a bleeding event, they are generally excluded from the trial. So we have not long observation, and we cannot have a clear interpretation of the data at long term. And also that we have to consider that a score of the underlying CAA pathology at the baseline has never been properly investigated and considered in previous clinical trial. And last but not the least, both MRI and PET are relatively non-specific marker for the CAA pathology. What I mean is that MRI is looking for hemosiderin deposits that are related to iron deposition, but not all the black spots that I show you are necessarily related to amyloid deposition. So MRI is not a direct marker for amyloid, while the PET imaging, even if you used a tracer specific for beta amyloid, we know for sure that these tracers are able to bind fibrillary beta amyloid, so plaques, the deposits in the brain, but they are supposed to also bind CAA, but there is no clear data, and it's not possible to discriminate the binding of the tracer to the plaques, so AD, or CAA, so the vascular deposition of beta amyloid, which is also slightly different, and we will see in a few minutes. And this is a very recent paper reported in the dominantly inherited Alzheimer's disease cohort, where they investigated the natural incidence, so the incidence of ARIA-H event, so related to, likely related to the CAA underlying pathology in this patient, and they show that there is a clear increase in these events during the disease progression. And the author conclude that, so this means that it will be very difficult, but also important to try to discriminate the natural incidence of these events due to the underlying CAA pathology and the incidence of the ARIA-H event that they are specifically related to the treatment with these anti-A-beta antibodies. And here is a list of all the monoclonal antibody currently in clinical trials, or the where we observe the main findings, the most important results. But before to try to discuss the main outcome and specific information on this drug, I would like to explain very quickly for those or you are not very familiar with beta amyloid. So beta amyloid is a protein that is generated by the processing of the amyloid precursor protein, which is a transmembrane protein, which is cleaved by different proteases and can generate this monomer, which is called beta amyloid, which is very insoluble, sticky, and tend to aggregate very, very, very rapidly and form aggregates and later on fibrils, which are insoluble deposits of this protein that can deposits in the brain of Alzheimer's disease patients. And so this is a typical brain of an AD, where you can see the shrinkage. And at pathology level, you can find the deposition of beta amyloid, insoluble beta amyloid as plaques or neurofibrillary tangles. But the same protein can also deposit in the vasculature. So here is a magnification of a cellular vessel where you can see various degree of beta amyloid deposition in blue, and the deposition of beta amyloid around the vessel, not in the parenchyma, is called CAA, cerebral amyloid angiopathy. So although this protein is the same, because it's the same origin from the APP, beta amyloid deposited in the vasculature is mainly A beta 40, so it's 2 amino acid shortened that the beta amyloid 42, which is mainly represented and present in the brain parenchyma as amyloid plaques. And so this is the reason for why we have different antibodies, and each of these antibodies is specific for a different epitopes along the full structure of the beta amyloid that span from the 1 to the 32 amino acid. And so each antibody can have different effect, and so they can reflect different outcome in fighting the disease. And the mechanism of action of all of these antibodies has never been proved in vivo, but the 3 most accredited mechanisms are the 3 reported here. And the first one is a direct effect of the antibody that is able to bind the plaques, and so to disassemble, to disaggregate plaques and release the soluble monomers that can be then removed from the brain to the CSF and vasculature, and so removed by the brain. Or another putative mechanism is an activation of the microglia, which is supposed to be the main actor in removing beta amyloids from the brain. So the antibody can bind to microglia, activate them, and then can activate phagocytosis of microglia that can digest the plaques. Or the third mechanism supposes the peripheral sink mechanism, which means that any effect of this antibody can bind to the blood, so they don't need to even enter into the brain parenchyma to bind the soluble form, and so they can recall more beta amyloid from the brain, and so delay or avoid the aggregation of these species while they are produced. But the mechanism of action of any of these antibodies is far to be completely elucidated yet. Why I told you that? Because if we try to look at all of these antibodies, and we try in particular to observe the binding domain and the binding target related to the incidence of ARIA-E, as we can see here in red, all of these antibodies are targeting the fibrillar, so the insoluble and deposited beta amyloid in the brain parenchyma, so amyloid plaques. And as you can see, all of these antibodies, they can lead to an incidence of ARIA-E, which span from 35 to up to 55% in patients, particularly ApoE4 carriers treated at the higher dose. While if we try to see a DBAN antibody, which is an antibody that binds both plaques and soluble and insoluble protofibrils. Protofibrils are the last stage before deposition in plaques. So it means that there are both soluble and insoluble form of large aggregates that then they can deposit in the plaque along the disease course. So if you attack these protofibrils, the incidence of ARIA-E is reduced to about 10%. And lately, if we try to see from the green antibodies, which is called solanezumab, crenezumab, or ponesimab, these antibodies, they don't bind plaques, but in particular, solanezumab was designed to evaluate the sink effect. So it was designed to bind soluble monomeric form of beta amyloid and in the blood in order to remove and to recall more beta amyloid. And this antibody has no ARIA-E effect. So there is no ARIA-E events reported after treatment with this antibody. But we have also to say that with this antibody, it was not able to show any clear removal of beta amyloid from the plaque, from the brain by amyloid PET. And for this reason, this drug, the trial was stopped. Cranezumab is another antibody designed to attack monomeric and soluble oligomers of beta amyloid. Again, if you attack insoluble beta amyloid, there is no ARIA-E reported, but again, there was no clear effect on the removal of beta amyloid from the brain. And lately, if you try to use an antibody that is specifically bind not to target beta amyloid 42, so Alzheimer's disease plaque, but beta amyloid 40, so the main form in the vasculature, deposited in the vasculature, there is no ARIA-E reported, but again, there was no clear effect in the removal of beta amyloid from the brain. And this is the reason for why all of these 3 trials have been stopped in the recent past. But another very important aspect that attracted my attention is that if we try to see the results on biomarkers after treatment with this antibody, all the red antibody, you can see that they demonstrate a substantially reduced amyloid PET on SUBR, so reduce beta amyloid from the brain after treatment, and a reduced level of tau protein, which is a downstream marker of neurodegeneration. But no one of these drugs clearly demonstrated a decrease in increase in beta amyloid 42, which was quite attended, because if you are removing beta amyloid from the parenchyma and the mechanism is a dissolution, a removal of this beta amyloid, what is going on then? I was expecting to see an increase in the CSF or into the blood, but there is no evidence on these effects. While there is only reported an increase CSF A-beta 42 after treatment with solanezumab and to some extent with cranezumab, which they don't demonstrate a clear reducing in amyloid, parenchymal beta amyloid. So this point the attention to cerebral amyloid angiopathy. And in my opinion, cerebral amyloid angiopathy has never been so important today for the success, for the future success of these anti-A-beta monoclonal antibodies, so for immunotherapy of AD. And the reason for why is that in the recent past, we demonstrated that ARIA-like imaging abnormalities can also occur spontaneously in these patients that are affected by cerebral amyloid angiopathy related inflammation. The acronym is CAA-ri. CAA-ri is a rare autoimmune encephalopathy which is associated with an increased cerebrospinal fluid concentration of spontaneous anti-A-beta autoantibodies where we found an increased production and presence of this antibody in the CSF of this patient during the acute manifestation of the same radiological manifestation that mimics the same ARIA-like. So CAA-ri is reflecting the same iatrogenic imaging abnormalities that we shown during an ARIA events after treatment with a therapeutic antibody. And the disease was first described in 2004 and was reported in a very small case series of patients and was presented as a rare and aggressive inflammatory syndrome presenting only in a subset of sporadic CAA patients. And again, you can see here the similarity with ARIA, because the presentation of symptoms, they can span from a rapidly progressive cognitive decline, behavioral change, seizure, all different symptoms related to cerebrovascular diseases. And the MRI findings are very clear and very similar to the ARIA, because our asymmetric and bilateral white matter hyperintensities due to vasogenic edema or sulcal effusion as ARIA-E, and microbleeds, cortical superficial siderosis as ARIA-H in clinical trials. And for this patient, we also had some reports, pathological reports, where you can also see that there was a deposition of beta amyloid around vessels. So there is a CAA, and there is also the recruitment of inflammatory cells at the level of the affected vessels. The mechanism, however, was still unknown at that time. And this is when we had the idea to try to investigate if the key player of this CAA-ri disease was mediated by the production of spontaneous anti-A-beta autoantibody, because there was coming the first report on ARIA-E at the time in 2011. And so I spent 2 years in the lab to try to set up an ultrasensitive technique for the detection of these anti-A-beta autoantibodies, because they are present in a very low concentration in the CSF. And so it was impossible to detect by regular ELISA these antibody in patients. And so we developed this technique that is a two-step technique based on functionalized magnetic beads and an inverted ELISA to specifically dose the concentration of these antibodies. And we were lucky to demonstrate that during the acute phase of the disease of CAA-ri, so when there is an acute ARIA-like presentation, we found a 3 times increase of these autoantibody compared to different groups of control patients, not only healthy control, but also non-inflammatory CAA and multiple sclerosis patient as a control for the autoimmune and inflammatory response, but that not related to amyloid deposition. And what that was very interesting is that after the clinical and radiological resolution of the disease, so in the remission phase, the same patient, they have a returning of this antibody in the same levels that we found in the control groups. And again, as you can see in these cartoons, you see that during the acute phase, the level of both A-beta 40 and 42 were increased compared to the levels that we found in AD and CAA patients, while during the resolution of the disease, when the antibody they reduce, the level of beta amyloid and for 40 and 42, they return below the cutoff, meaning that they return in the same cutoff that we use every day to diagnose Alzheimer's disease patients. And the same happened for CSF tau and phospho-tau, the downstream marker of neurodegeneration. And another interesting findings was that during the acute phase, the increased concentration of these antibody, they were strongly correlated with the amount of both beta 40 and 42 present in the CSF. And so for the first time, we hypothesized that the mechanism of action of this antibody is by the removing, disaggregating beta amyloid that can lead to this association, so to increase level of the soluble form of beta amyloid that you can in effect dose in the CSF. Another important findings was that in the same patient, this one from Japan, we were able to have a lumbar puncture, so to take the CSF and to evaluate the dosage of this antibody, the concentration of these autoantibodies. And after each steroid pulse that we administered to this patient, there was a decrease of this antibody, meaning that the disease can be treated by high dose of steroids in order to reduce this antibody. And then when these antibody they resolve, they disappear, the disease resolved, and you don't have any clinical or radiological evidence. And so for the first time, we propose this, the disease CAA-ri as a human model of spontaneous ARIA, for the study of spontaneous ARIA in clinical trial. And thanks to the visibility and the importance of these evidences, several other papers, they come out later on, and we start receiving a lot of requests to these antibodies. And we were able to also to demonstrate that CAA-ri can only spontaneously occur not only in CAA, but also in cognitive normal adults, in pre-symptomatic Alzheimer's disease, as well as in sporadic and genetic Alzheimer's disease patients. And we were also able to start looking for the recurrence rate of these events, and also to see if there was a similarity concerning the amyloid PET evidence that I show you for bapineuzumab and gantenerumab. And as you can see here, this one were patients affected by Alzheimer's disease that they develop CAA-ri events, and in the same brain area where they develop a CAA-ri, so ARIA-like, there was a reduction on the amyloid PET tracer finding. But this one was made after a few months from the acute events. And here in another patient, we were able to see the same, even if I will say not markedly evident, but there was a reduction of the uptake of the PIB tracer in these patients. And this PET scan was administered 4 or 5 months after the acute presentation of CAA-ri. What that we are not able to have now, and the main reason is because of the lack of funding, it will be very important to evaluate the amyloid PET scan during the acute phase and after for a follow-up and after several months, because it will be very important to see if the disappearance or the removal of this beta amyloid has a long-lasting effect, or when the antibody they return below the physiological level, the beta amyloid start deposited again, and so you can have a redeposition of beta amyloid in the same brain area. Here is another very well described case that hopefully we will be able to describe and to publish soon, where you can see in a very acute phase of the CAA-ri presentation, again in the same brain area where the ARIA-like imaging appear, there is a complete disappearance of the uptake of the amyloid PET tracer. Again, confirming that at least when you have an increased amount of antibody that in the acute phase, it seems that the beta amyloid is massively removed. So mimicking what that I show you with monoclonal antibody, therapeutic monoclonal antibody. And here is a recap of these similarities between spontaneous ARIA-E-like events in CAA-ri and ARIA in immunotherapy trials. And so there is an increased concentration of spontaneous autoantibodies against beta amyloid in the CSF of these patients compared to ARIA in clinical trial where the antibody are therapeutic. And the increased concentration of these autoantibody correlate with the soluble A-beta 42, 40 tau, and p-tau in the CSF. And the ARIA-like in CAA-ri are thought to develop as a consequence of the antibody-mediated removal of brain-deposited amyloid, both supported by CSF and amyloid PET, as I show you. Although, at least at the beginning, most of these cases, they were reported as very severe presentation. CAA-ri was very severe presentation. And so there was a debate about the real similarity with the ARIA in clinical trial, which are today, most of them asymptomatic. I will say that this was typically due because of the unawareness of the disease. So if you don't know the disease, you cannot search for that. And so you cannot recognize and diagnose the disease. Today, that the disease is becoming very rapidly recognized also in the neurology community, more incidentally diagnosed cases and very mild symptomatic cases are also reported in CAA-ri. And also the CRI may present not only in CAA, but in sporadic and genetic AD, as well as in other neurological manifestations linked to aging and so to the deposition of beta amyloid. And another important findings was the one that the ARIA-like in CRI as a transient but potentially recurrent nature, which can be managed by the administration of steroid therapy. And the last similarity is the ApoE4 genotype association with CRI, which is overrepresented in this patient as well as in ARIA-E in clinical trial. So again, we propose CRI as a human spontaneous model for therapeutic induced ARIA, where by removing the beta amyloid, these antibodies may paradoxically lead to a temporary overload of soluble amyloid, which can lately increase the vulnerability and the cerebrovascular architecture of this patient, which carry the risk for bleeding events because of the CAA underlying pathology. And in 2016, we also published the first clinical radiological diagnostic criteria for the diagnosis of probable and possible CRI, in which the CSF withdrawal is still mandatory to confirm the diagnosis because still remain an exclusion diagnosis. But very important question, they still remain open, such as this was proven in biopsy or autopsy proven patient in order to validate the criteria. But of course, you are performing a biopsy in this patient only when you have a suspect, and so this patient, they are probably the more atypical or the more severe presentation. And so you would like to really investigate the disease. So there is some concern about maybe the generalizability. And also the need of a biomarker is very important because, as you can see, these criteria, they work very, very well for the diagnosis of probable CRI, but there are some margin to increase the specificity, maybe by adding new biomarker for the diagnosis of possible CRI. And also we have to understand which are the risk factors or the prognostic predictors of the disease, and lately to write some treatment and management recommendation, because now we are able to make the diagnosis quite well, but there is no recommendation or guideline on how to manage, on how to follow, and how to treat these patients. And only large cohort registry of very well-defined and longitudinally monitored cases will allow to make progresses to try to understand these open questions. And this is the reason for why we found and we established the ICAB International Network, that is a spontaneous network of leading experts in CAA and Alzheimer's disease, and also all neurologists that they can have one of these cases in the clinic, in their clinics, they can contact us, and spontaneously they can enter into the network and so provide important information to discover new biomarker and to understand the disease and to discuss about these recommendations and to understand how to treat these patients. And today, the ICAM network accounts for the largest longitudinal cohort of CRI with more than 550 CRI and also biopsy-proven cases, sporadic non-inflammatory CAA, and also AD patients. And this open to the last part of the talk, where I would like to talk about this study, which was focused on the natural history of ARIA-like in CRI, because there are, as I show you, some findings suggesting that CRI could be reversible and responsive to immunosuppressive treatments. However, these evidence, they come from literature review findings from small case series or even single case studies, and mainly from single centers. And so this is the reason for why we do not have a formal consensus among the experts. And taking the advantage of this network, we were able to, for the first time, to evaluate the natural history of the disease in the longitudinal cohort of these patients. And the final aim was to describe the natural history in terms of the onset of the disease, prognostic predictors, and treatment-related outcome, both a short and long term. And as you can see here, these patients, our cohort is 5 years older than former small case series previously reported in the literature. And 1/3 of our patients, they also have a previous history of a mild cognitive impairment of Alzheimer's disease, which is a prevalent never reported before in CAA-ri. And 1/3 has an history of previous ICH, which is the, I would say, strong marker for CAA pathology and disease severity. We also confirmed the high prevalence of ApoE-epsilon-4, which is in line also with the data that I showed you for ARIA in clinical trial and for population of Alzheimer's disease. And also, for the first time, we have a cohort with 37% of patients which presented only with one symptoms. And this, we believe, is reflecting the increased awareness and recognition and the diagnostic capacity by the neurology community, now that the criteria has been also published and so are published available. And also it's very interesting to see that we found a kind of dose-dependent distribution of the microglia number. So the amyloid burden in terms of CAA in our cohort increasing from 7.1% with only one microglia to 50% of patients, 60% of patients with more than 10 microglias, meaning that and also CAA, cortical superficial siderosis, which is another marker of CAA severity. And this means that CAA matters for ARIA-like presentation in CRI for the disease. And also this is not surprising because this well known that there is a relationship between CAA and Alzheimer's disease. And I would like to remind you that CAA is very frequent in the elderly population, but also is found in almost all patients with Alzheimer's disease on pathology study. So this means that CAA could be. It's not surprising that our patients are also Alzheimer's disease patients. And so this means that the severity of CAA is a potential risk factor also for ARIA-like. And we also look for the incidence probability on the survival, the relapse and clinical recovery, radiological recovery, and the development of new ICH, new macrohemorrhages. And as you can see here, the prognosis in our cohort is quite good for this potentially very severe disease, as most of the patients, they have a clinical recovery within 3 months, 80%, increasing to 84 at 24 months. And the radiological recovery have a shift of 6 months because we can reach the almost the same percentages at 12 months, while at 3 and 6 months is reduced. But another important finding is that if you don't reach any clinical or radiological recovery within 24 months, it is unlikely that you can recover after. Another important findings is that relapse can occur. The probability of early relapse is quite low, but late relapses can occur in 38% of patients, which is quite similar to the 35% rate of ARIA relapse reported in clinical trials. And another information is that ECH, the events developing shortly after recovery, it worsens prognosis. and that ICH, the incidence of new ICH, is related to the baseline cortical superficial siderosis, the presence of CSS. I think that I'm late, so it's better to run. Another important findings is that we try to look for prognostic predictors of CRI. But as you can see here, none of the marker of the characteristics that we evaluated at baseline was associated to a prediction of CRI, of recovery, for clinical recovery at follow-up. And this means that the amyloid burden is still remaining relevant as a risk factor for the incidences, for the occurrence of CRI, but what is governing the prognosis, so the history of the disease after the first event, is probably mainly related to the inflammation, so to the inflammatory and autoimmune processes that are governing the CRI after the occurrence of the disease. And this is the reason for why this manuscript is currently under review and hopefully will be available soon. But this manuscript also generated this further study that we are now preparing the manuscript, where we try for the first time to evaluate longitudinally the in vivo imaging of microglia activation during the course of spontaneous ARIA-like events in these patients. And this is important because, as I told you at the beginning, ARIA-E are likely due to inflammation, but flare sequence on MRI, they are not directly capturing inflammation, but flare MRI sequence are looking for water mainly. So this means that there is a recall of water, and the water is strictly associated with the inflammatory process, but is not a direct marker, it's a surrogate marker of the MRI. And so this is the reason for why to demonstrate that there is a true inflammatory activation, the ARIA-E, is important also to understand the mechanism and to understand how to manage the likely occurrence of this event. And so by a multimodal, by cerebrospinal fluid dosages and neuroimaging, and multiparametric by CSF, where we investigated all the ATN biomarker and the A-beta antibody, MRI with all the specific sequences, and also the PET imaging with the PK, which is a specific tracer for activated microglia and FTG. We try to follow these patients longitudinally and see what happened. And what we found is that for the first time, we were able to provide the in vivo evidence for microglia activation associated with ARIA-like white matter hyperintensities in CRI patients. And also important that we confirm that all of the patients that we investigated, they have increased anti-A-beta antibody at presentation and decrease after the resolution of the ARIA-like events. And another important findings is that there was an association between ARIA-E and on MRI and the focal cluster, so focal cluster of microglia activation colocalized with ARIA-E on MRI. And at follow-up, we found that the microglia activation cluster, they reduce only when the ARIA-E on MRI reduce, while patients where the ARIA-E, there was still an evidence of ARIA-E at the follow-up. There was some evidence also on PK-PET binding. Another important information is that, intriguing information is that we also find some very scattered cluster of microglia activation reduced compared to the one co-localized with ARIA-E, but co-localize also to the CAA marker on MRI, so meaning with microbleeds or microhemorrhages. And this can have different interpretation, may suggest that there is some background neuroinflammation that is linked to the bleeding events, which is also reported in the past on stroke studies, or also that there is a kind of inflammatory surveillance after the ARIA-E events, meaning that when there is a focal inflammatory event recognized as ARIA-E, you can you can activate inflammatory cells that can patrol the whole brain, and so they can also move to other area, and maybe this can be the new foci for recurrence in at longer for follow-up. While we found that neuroinflammation was unchanged between the baseline and the follow-up in the brain area associated with ARIA-H-like marker, meaning that neuroinflammation is not acutely activated only during these events, but is likely related to CAA, so background inflammatory events that we know can occur also on CAA. So to conclude, ARIA-A is a phenomenon associated with microglia activation, as previously suggested only by ex vivo study with the gantenerumab, and so we provide the first supporting evidence also for the potential use of corticosteroid therapy also in patients subjected to immunotherapy they can develop that develop ARIA-E. Key messages so are that ARIA-like in CAA are not so rare manifestation affecting only sporadic CAA, but we should expand the notion to the wide spectrum of the inflammatory manifestation of all diabetes-driven pathologies of aging. And the importance of differential diagnosis is very important in the future to try to separate the incidence of these spontaneous ARIA-like events from the therapeutic one, and that ARIA-like is also amenable and reversible. So these patients are responsive to corticosteroid therapy, and also the importance of early diagnosis and treatment. And so A beta autoantibody test that we develop can be very helpful in the diagnostic process, but also as a prognostic marker in order to also follow the therapeutic response and the prognosis of these patients after treatment. And another important finding is that we found that after steroid therapy, high-dose corticosteroid therapy, is important to maintain a very slow tapering off with oral steroids, because we found an effectiveness in the administration of tapering in reducing the incidence of further recurrence in these patients. And again, it's important to do not underestimate any new symptoms in patients that they originally have the first index event, but also we suggest to evaluate very carefully the occurrence of acute clinical manifestation in AD patients in memory clinics, because some of these patients, they can develop some ARIA-like, so CAA events. And to conclude, here is the ARIA paradox etiologic mechanism that we propose based on the findings that we collected in the last 10 years, and is that if you treat an AD patient at the very prodromal stage where you have mild CAA, both the spontaneous antibody or the therapeutic antibody, they can safely remove beta amyloid. They can so pass to the blood and be removed. But if you treat patient later on the disease stage, when you have a more severe CAA in these patients, and also you have an high amyloid load in terms of more plaques deposited in the brain, these antibodies, they can lead to a massive removal of soluble species that they need to pass the brain to be removed. And so they can increase the CAA severity, at least temporarily, because this beta amyloid removed the antibody is sticking to the underlying CAA pathology, and so can accelerate or exacerbate the bleeding events and the subsequent inflammatory events. And these implications are very important, and the ARIA implications are very important in clinical trial, particularly now that ADUCANUMAB is available into the market, so it's largely accessible for all AD patients, because we have to understand if an increased dose is more effective, but will be more harmful in terms of increasing incidence, or on the contrary, the titration plan are safer in terms of the incidence of ARIA, but less effective. Or another important consideration is that if we saw that most 80% of the ARIA-E reported in clinical trial are asymptomatic, and we know that the MRI scan is performed by per protocol only by month by month, how many of these asymptomatic manifestations have been missed between one scan and the other one? Maybe the incidence of ARIA-E can be higher than what we know today. And to solve this issue is important because this can generate future patient complaints because of the issue on developing this potentially severe side effect. But also we have to understand the long-lasting clinical implication of an ARIA. And also we have to consider, because of everything that we saw now, how the data that we have today from clinical trial are really the interpretation of these data are really generalizable because of the many issues that we saw. And so also how this can impact on the results that we are interpreting now in terms of efficacy and incidence of ARIA. And this will be important to guarantee the sustainability also of the health system. And so new biomarker, more accessible and less costly than MRI, will be needed. Otherwise, all the health system, they will collapse if this drug will be, available to a large number of patients. But also it's important to understand why and how this drug works. And based on the ARIA paradox, the mobilization of a beta achieved by this antibody is caused by a transient increase of ARIA due to the underlying CAA pathology. This also means that we have to be extremely careful to treat patients that we know they have CAA, because CAA is a disease related to bleeding. And so if this drug can induce more bleeding, it will be more harmful than the positive effect that these drugs can exert in terms of removal of parenchymal beta amyloid. To conclude, so in my opinion, the future game changer will be combination therapy to really fight Alzheimer's disease, and hopefully also find a drug or a therapy that can solve also CAA pathology. And in particular, I think that pre-treatment or co-treatment strategies will be very important, such as pre-treatment with a monoclonal antibody, such as ponesimumab, targeting beta amyloid, which is not inducing ARIA-E based on previous findings. We can safely remove beta amyloid from the vessel, so we can treat CAA, and then we can administer aducanumab or the other antibody gantenerumab will be available hopefully in the next future. And so the beta amyloid removed from the parenchyma can safely be removed also from the vasculature. Or we have also to investigate the potential use of co-treatments, because we know that this drug, they remove beta amyloid, but we don't know yet this beta amyloid, what is going on. it should also be that by removing the fibrillary deposited form, we are releasing more toxic species, soluble species. And so co-treatment with compound able to bind these soluble species will both avoid further aggregation in CAA or in the parenchyma in the future, and also sequester, and so avoid the exerting of some toxic effect of monomer, the small monomer. And this is what we would like to do in the future with our cohort. And so large biomarker discovery study, validation study of our technique that we developed for the antibody, and also to explore new antibody by new technologies like the single molecular array, SIMO, or other automatic technique to find the right biomarker for diagnosis, prognosis, and treatment monitoring. And also to try to develop a multimodal data integration tool with the hope to predict the incidence of ARIA by combining both amyloid PET images, MRI images, and fluid biomarker, not only in CSF, but hopefully also in the blood. And this will be only possible by supporting the establishment and financially also support the longitudinal registry such as the ICAM International Network, because only the availability of large cohort of patients very well characterized with a long follow-up and with the biobank related samples will be available to address all of these important questions. So only by working together we will really make progresses, and let me to thank all the collaborators of the ICAM International Network and the CA study group of the Italian Society. Thank you.